Welcome to another episode. My name is Bodine Ledden, and today I'm joined by a very special guest, Brad Hiskins, and we're going to be talking all about things to consider in an initial consultation. Brad is a very experienced soft tissue therapist with over 30 years in clinical practice. He's worked at the Australian Institute of Sport for 11 years, and he's been involved in 5 Olympic Games, 2 of those as head of service, and also 2 Commonwealth Games, both as head of service. Brad has extensive experience in the sporting world, including being president of Sports Medicine Australia, the ACT branch. He's also presented both nationally and internationally at conferences, and he has taught at the Canberra Institute of Technology for 12 years. Brad is also the director and principal soft tissue therapist of Clinic 88 in Canberra. But among those great achievements, Brad also holds personal records for the largest carp caught in Lake Burley Griffin. But let's kick off the podcast. We'll dive straight in. All right, Brad, thank you so much for joining me on this podcast. It's great to see you, and I'm really keen to hear your knowledge and your perspective on such a valuable topic. It's what to consider in an initial consultation. And I know that you do a lot of mentoring with recent grads. You do a lot of mentoring with your staff on a regular basis. So what are some key things to consider when we're looking at an initial consultation?
Well, one of the sort of the main complaints of the last 25, 30 years that I've seen with students coming straight out of school is they've learnt a reasonable skill set and they've learnt some assessment, but they don't know how to put those two together. I think most people would agree with that, with what we've seen in the last 25, 30 years. So what I've done is, and this is for experienced therapists too that might not have a mentor, haven't been in a clinic situation, so they're trying to learn it themselves, is to try to compartmentalise an initial assessment and create boxes. And even on that box format, I use Clinico. We use Clinico, something even Jimmy Barker can use, which was our premise for using it. So if he could use it, then anyone could use it. Sorry, Jimmy. And we've actually created a tile format for initial consultation, where it literally just have these 10 boxes. So as a young therapist, instead of going, I don't even know what I'm looking for, what should I look for? I'm lost. Oh my God, there's someone laying on the table, there's someone sitting on the table, and I don't know how to start. So this steps you through what you should look for. In my opinion, now, like, there's 10 things that I look for, and you can make it 30, you can make it 50, you can make it 5. It really depends on you. But I've got it down to 10, which I'm quite happy with. And underneath each one of those 10 dot points is a lot of other dot points that you can add as your knowledge grows.
Yeah, but it's all about structure, isn't it? If you've got structure, you know where to go or what that next step is, you can gather a more robust assessment, and that can assist with that appropriate treatment planning, right?
You just start with a nice little concise base, and it grows from there as your knowledge and experience grows. Look, when it comes down to it, the basic components of any treatment, from what I can see, is 4 parts. You've got your assessment and protocol setting at the start. Then you've got your treatment and rapport building in the middle. So you're laying on of hands, your techniques and so on, plus you're building that rapport with the patient. So to me, that's incredibly important, because we've had some therapists in the past that are really not great at assessment, are really not great at protocol setting, but their rapport building is extraordinary. So that's an important part. Then at the end, you've got your reassessing and your development of your home strategies. I think that's where people really struggle, is I'll reassess and go, well, the hamstring length's better, and which is good, isn't it? And they don't know what to do at home. So this is where this box scenario helps with that. And then there's the rebooking or referral, which is the 4th part for me. So if you don't get those first 3 parts right, then you're really going to struggle with the rebooking, because on what premise are you rebooking? So that's 4 parts to any treatment in my mind. And I really try to, with all the mentoring I do, try to get those 4 parts down pat and make sure that each is given an amount of time to do it properly, especially that bit at the end, the reassessing and home strategy. So that's the 4 parts. But then when you get down to these 10 parts, let's say an initial assessment, what are they? And they're things that we need to look for. And once we can tick that box saying, yes, this person has that component, and we go, good. Now that forms a part of my treatment protocol. It also forms a part of my home-based protocol. So at the end, if you've ticked that box, then you can say, okay, I'm going to treat that. And now at home, I want you to do this. So you've already given them homework. Plus, it means that when it comes to rebooking, you can say in 5 days' time, 10 days' time, whatever you figure out, you can say, well, in 10 days' time, I'm going to check and make sure that the homework you've done has now ticked that box and you've complemented what we've done in the clinic, and then we can move on from there. So it means the person's got a reason for coming back and you've got a reason for seeing them.
How important is that? Framing it to the patient so they understand what to expect over a certain time period. And so it makes both them more accountable and also the therapist more accountable as far as that treatment planning process and follow up, as opposed to just come in, how you feeling today. It's about reviewing what the process, the symptom behavior has been over the last 5 to 10 days, whatever that looks like. And then what are the steps going forward? Patients really do love and appreciate that plan, so they know what's next. It sort of clears up that unknown.
Yeah, exactly. Yeah, they go home, they know exactly what they've had achieved in that session, what they need to achieve in the next period of time. And when they go back, they know that the therapist is going to check those things. And you as a therapist, instead of them going, what did I do last time? You've got those, all right, of the 10 things, I've marked down 4, so I need to reassess those 4. So you can say, Bo, great to see you, mate. How you going? How's your week been? Hope your football team lost. And then you can go through those 4 parts. Is that, okay, how did that knee go with the swelling? Did you go through the swelling protocol? Let's have a look. Excellent, you've done a great job, tick. Let's have a look at these other 3. So they can see the structure. You can, well, it's more for the therapist. So the therapist can see the structure. So they understand that in that rebooking, is that this is what I'm now doing, and we're getting that person closer to where they want to be.
Yeah. Yeah. And look, Brad, you touched on some great things before, and one of them that really stands out to me is you mentioned the rapport building. And, I've worked alongside you. I was mentored by you early on. And something that always stood out for me is your ability to build rapport with people. So talk me through like how important that is, and when we think about that in the context of pain and ongoing treatment over a period of time.
Well, I do a lot of mentoring on retention and attraction, which is any therapist that wants to have a successful career, however you define that, financially or whatever. So you need to be able to retain clients and attract clients, all right? So, and there's plenty of ways you can do that with a great skill set, with great knowledge, with the ability to have verbal diarrhea like I tend to have, but also just that rapport. So I go back to one therapist who I had who wasn't great at assessment at all, really not great at forming a prognosis or protocol for anyone. I'm thinking, oh, this person might really struggle. But that person's ability to smile at the patient when they walked in the front door, say things, I think, oh, that's inappropriate, but then they loved it and they're laughing out loud. By the time they got that patient to the hallway before they even got in the room, that person was 100 times better. They were smiling, they were laughing. I could hear them laughing in the room, just having a great time, while obviously doing a proper treatment, obviously. And that person was rebooking before they even got to the front door, because that rapport that person built was extraordinary. And I'm not saying everyone should become your patient's best friend, but that was just an example of me thinking, wow, it's not all about being, you don't want to be that specialist, I think everyone's been to a specialist and they've got that stone face. They don't look at you, they're monotone. You walk out thinking, that was bloody terrible. You're not even sure what they've achieved because you're so disappointed with that person's attitude. It's very difficult to find a positive outcome. Even if the specialist gave you something reasonable to do, you're going to go home to your spouse and go, that person was just an idiot. I just didn't like them. So that rapport in the middle, that relationship building, that rapport building, to me, is super, super important. And it's something which I probably got beaten out of me when I was young. I was told, whatever you do, don't form a strong relationship with the patients. I was told not to form any relationship with the patients. You don't want to create that, what's the word I'm looking for, Bo? When they feel they need you, struggle, need another coffee.
Oh, yeah, I can't help you there.
Dependency. They're saying, you're not allowed to form dependency. It's terrible. Don't do it.
Transference is the word. Is that the one you're looking for?
And I sort of went along with that for quite a while. And after a while, I thought, sometimes these people need to feel that dependency for a period of time because they're scared, they're worried, they're in pain, they're in dysfunction, and they're like, I can't control this part of my life. So if you can go to a clinic where you can contract that part of your life out, going, I can't control this. Bo, can you please look after this? I'll contract you for a period of time. I'm going to feel a bit dependent on you for this, and you take on that dependency, but it's only for a period of time. And that rapport building can be, let's talk about something quite personal. Let's talk about the footy. Let's talk about your dog, which, of course, specialists are not going to do. But that person immediately goes, this person understands me. They're here with me. It's sincere. It's not just, I'm going to put my elbow in your bum and, excuse me, while I stare at this wall for a while. I only think, yeah. So, and when you get that person's confidence, they start to come good, then you can draw back and let them go. Because obviously our whole role is to educate the patient over a period of time so they can look after themselves.
Yeah, and that's, I think it's such an important point that's often overlooked when we think about and talk about the therapeutic alliance. Building that rapport allows us to build trust, demonstrate empathy, and all of this can have a significant effect on a patient's pain experience. But if you're just looking at their patient history form and then using that to develop your opinion, and it's sort of like, all right, let's get straight into the nuts and bolts of this sort of stuff. There does need to be that period where you do spend that getting to know them and building that trust and rapport. And I think that is the importance of that therapeutic relationship there. So it certainly plays a significant role.
We've gone and put three big fancy Latin words together and created biopsychosocial model, which to me is, get in trouble for saying this, I think it's the most overrated philosophy we have. And I think a lot of people have just relied on it and gone, well, this seems a bit difficult. I'm not sure what's going on. Let's draw three circles and put a stick figure in the middle, and this is you. So you've got this biopsychosocial model thing that you need to go figure out yourself. But it's still there and it's still important. I just think we overplay it sometimes. It makes us a bit lazy. But that biopsychosocial model is all about that person not feeling comfortable in their environment, don't understanding it, and they've got this fear factor, they've got this anxiety, and then that hypersensitizes their system. So if you go to see someone that doesn't show you any form of sincere appreciation as a human, they're not going to feel any better about the biopsychosocial model. So you need to break it down, form that relationship like you're talking to your neighbour, where they go, I can see what this person's saying. Okay, all right, I trust them because I can see they're talking to me like a person rather than like a patient. So that rapport building in the middle is huge. And as I said, it forms that trust. So they go home and they say to their spouse, I saw this person today. Geez, how good. It was fantastic. I learned so much because you did it in a manner where you smiled and had a bit of a joke, and you changed your tone, and you might even drop a swear word here and there. Here in the country, you have to drop a swear word if you don't, because you must be a weird city person. So it's dropping the professionalism a little bit that I learned early in my career, and just being a good, fun person to deal with as a patient.
Yeah, but that gives you so much of your history in that conversation, right? Because you're picking up so much from it. You might pick up that they're stressed, so they've got certain life stresses or work, or the different coping mechanisms, that without directly asking that question, like you're going through an interview and go, all right, question 2, how many hours a night are you sleeping? And so that's very formal. But if you do that in a conversational setting, we can gather so much from that history. And the history is that forms a robustness of our assessment. You said before about hypothesis forming, right? Because that's what forms the assessment, right? We're looking to confirm or deny that hypothesis that we've generated in our history.
Oh, you learned well, though. Can't believe you can remember it. Yeah, this is right. So it's again, I go back to you take your experience as a patient yourself. So you go and see someone else, a dentist, whoever it might be, and that first couple of minutes, you can feel almost being reserved sometimes, where you think, well, this person is not here with me, and they ask you some question where they're looking out the window, and you can tell them, and you think, oh, stuff, I'm not going to tell you. That first couple of minutes with that big smile and that demeanor and the gestures and the little joke, I just said it calms them down. So the patient's more likely to say, by the way, my cat died last week and I've had a shitty week and the hip's 10 times worse. So you know that there's something else going on that you have to consider. And then you change your expectations accordingly. You might change your whole assessment, your treatment plan, because you think, well, this person is going through a lot of anxiety and therefore it's going to heighten response. So I'm not going to do anything aggressive and quick, and I'm not going to give them a lot of homework because they're not going to do it. It's just going to burden them. So again, it's that creating that rapport, that trust, so the person's more likely to open up and tell you the whole story and not deny that they fell off the horse last week because they were embarrassed. Or they're shitty because their football team lost the last 10 straight games, which has been made.
You must be used to that, yeah.
Developed a little twitch.
But yeah, and that's so valuable. I think for new grads coming out, they often feel like they've got to get straight into the thing. They've got to do the thing and do the treatment. But it's important to remember that history taking, that building the rapport and trust is part of the treatment. It is part of that whole consultation, and neglecting that could sort of significantly affect the progress and the rebooking in those later stages that you referred to before.
And Bo, as the years roll on, I'm doing more and more sessions where I don't treat at all. It's just talking. So I have patients come in and say, listen, I've got this blah, blah going on. Can you just talk me through what the hell is going on? What should I do? What shouldn't I do? What treatments are available out there? What can you provide? What's my prognosis? And I feel for those people because they've often been to 3 or 4 different therapists who've just dived into the treatment and they've sort of got some result and gone, but I don't know where I stand. So these people want to have an understanding of where am I in space with this thing? What's going to happen in the future? What should I do now? And if you've got time and knowledge and you're prepared for that, then I can go through these dot points if you like, which we will in a minute. And a lot of, as the years roll on, people come in with repetitive stuff. Like some people come in with an osteoarthritic knee, which is obviously not my speciality at all. But they do wander into your clinic. So they're going to be there, they're going to pay. So what are you going to give them when they do walk in? So I've got handouts and sheets where I've gone, well, what I'm giving now from a gold standard point of view for my research is this. And often it's refer, and send them off to our exercise physiology department and so on, or off to the sports doc for some PRP, or there's a lot of new stuff coming out with OA. But I've got that sheet there. So that whole session, that whole half an hour was just, look, here's this sheet. This is how you use it. All right. So these are the things that might work. These are the things that will work. This is what to expect. This is the type of bandage you can use. This is the type of sleeve you can use, and make sure it's like this, and this brown's probably better than this one. And they walk away going, that is the best session I've ever bloody had. I didn't touch it. So that ability to sit and talk is completely underrated. And I often say to, especially the young ones I'm mentoring now, is that what comes out of these things is important, but what comes out of here is super important. And to have that ability to conclude a session, that last 10-15% of your session is often where you'll either win or lose a patient. Because if you do that, you know that thing that I hate, Bo, when that therapist says,
See how you go.
"Oh." It's just an admission that you don't know what you're doing.
Yeah.
It's rubbish. So you've got half an hour, 45 an hour, whatever your sessions are, to figure out what you're doing and why, and how you conclude that session gives that person confidence. All right, I want you to do A, B, and C according to these boxes we ticked. Oh, that's great. Rather than see how you go, they walk out thinking, see how I go. What does that mean? Do I go back? What do I do? So that last portion, incredibly important after you've built the rapport in the middle. And I think that sort of leads on to the next part for me, is that what are those points that I reckon you should consider?
Yeah, perfect. I love that, because if you don't spend that time going through those initial steps, it is very difficult to then educate them about the potential contributors and drivers behind this. But, if we can educate someone about those factors, that can significantly decrease their level of threat, their worry, their fear, their anxiety. It gives them a little bit more direction, and that can significantly calm symptoms as well when we talk about those psychological contributors to a pain experience, for sure.
Yeah. Yeah.
Okay.
Got it on the table.
Yeah, great. Okay, so let's go into those 10 steps.
Yeah, I've got
Not
10.
an AA meeting, is
It can be
it?
5, it can be 50. But initially, I'll sort of break it into two parts. Initially, you've got your acute injury stuff that wanders in, and then you've got your acute on chronic or insidious onset stuff. So those two. Now, the acute injuries, I'm glad I don't do a lot of those because I find them boring. Because your acute injuries, you've got a grade 2 biceps fem tear. It's 24 to 26 days and don't run. And there's a bit of load that goes on and depends on your patient. I suppose the point is that the prognosis is well known for those acute soft tissue injuries, whether it be ligament, whether it be joint, whether it be muscle. They're well defined. You can Google the things and it gives you a 24-day step process. There's actually a place in Melbourne, I probably shouldn't mention it, but there's a place in Melbourne where you can pay $4 and they'll send you the protocol for all those different injuries. So that's the acute injuries, but we don't see a lot of those in our profession. We see a lot more of the acute on chronic, insidious onset, I just woke up and my hip sore scenario rather than injury. So that's the part we're talking about with the 10 steps. All right. So this is not in any order. It's just things that you can tick the box. And if I look up this way, so I'm just making sure I don't forget any. All right. So the first part is there a swelling component? Pretty simple. Let's say it's a knee. Someone comes in, my knee is sore. I've got some soreness here, and here. To me, I'll always look and see if there's any swelling. And from that, if there is swelling, we've got a swelling protocol, which I'm not sure you remember, Bo, back in the days. So we can give them a handout. We can talk them through the handout, explain why swelling is important. Things like you got 10 mil of swelling in your knee, then we know that depreciates the activation of VMO. You've got 40 millimeters of swelling in your knee, it depreciates vastus lateralis. So we know how important it is. We don't just say, here, exercise physiology department, strengthen this knee, and it's swollen, because their ability to achieve their goals is going to be highly diminished. So having that swelling part, you can go, okay, you've got some swelling here, talk them through why ridding that swelling is important, which what I just said just then, is that your exercise rehab is going to be not efficient, not effective because of the swelling. And what is swelling protocol? So you can have your whole list of stuff there for the patient, your night wraps, your kinesiotaping, your compression bandages at different periods of time, and so on. What type of treatments that I can do as a therapist is there a lymph involvement? Are we going to do broad-handed sweeps? Are we going to do lymph taping with kinesio? What are my options? So as soon as you see the swelling, straight away, you got all these protocols. It's all there in your mind. And if you've forgotten, just grab the sheet off the wall. Okay, swelling protocol. So that's one part at the end. We go, okay, now you've got your swelling protocol. We're going to give you 5 or 6 days to try and reduce that swelling. As soon as you reduce that swelling, then we can move to the next phase, which is referring you off to the exercise scenario, and away you go. So that's one part. So is there a swelling component? So the second part is there an inflammatory component? I'll quickly read through them both, sorry. So we've got swelling component, inflammatory component, stiffness component. Is there a hypermobility or instability component? Is there a nerve component, which is obviously something that I love? Is there a postural component? Look at my posture. Everyone's got a postural component. Is there a conditioning component? Degenerative? Do they have something degenerative, which again change all your expectations because you've got an old cranky facet joint? You're not going to fix the thing, so it's going to change your expectations. Is there an anxiety component or a biopsychosocial model component? And the last one is, are they presenting with a known condition? Lupus, whatever the case may be. So you go, okay, all right, they're presenting with that, so I'm going to change my expectations. And I'm not going to try and fix this thing, I'm going to try to maintain. So that's a 10 right there. Okay, I can send you the list if you want to chuck it up for everyone so you can see the headings.
Yeah, I think that's great. Just having that structure to go through and see, what are these potential contributors? Make sure that you spend some time having a look at that so things aren't overlooked. And we see so often in pain presentations that, for example, the neurological component may be overlooked. Vascular components in more serious cases. But yeah, I think just having some sort of structure to that assessment process is really valuable. And in fact, I ran a workshop on the weekend, and one of the things that I always do in this particular workshop is I start with a case study, and the case study is just about developing an assessment plan. And a lot of the time, people just jump straight into, well, I would do range of motion, and then it's sort of like, well, what else are we missing? Have we screened for red flags? Have we taken that thorough history? Have we then gone through your active, passive range of motion? Then, what's next? Do we then start to funnel down into more of those special tests that have a look at the nervous system as well? And so it's sort of filtering down and to look at then strength and functional performance tests and so on. So then we can really develop a more of a robust assessment, and that forms your treatment plan from there, right?
Otherwise, we do range of motion tests and we try to desperately find something that's stiff, and you find something, you can unstiffify it with whatever technique you want, and you think you've achieved the goal. So when you've got all these boxes to tick, you can realize that if you've got someone who's hypermobile or even has den loss, then you think, well, what am I going to do with these? So, but if you don't understand that you need to look for that, don't even acknowledge it, then you're going to miss what the protocol should be. You think, well, someone's hypermobile, I don't need to make any more mobile. So what do I need to do in that scenario? And that's where, once you've got these boxes and you tick the hypermobility one, you think, well, what do I do now? So that's when you can have a what do I do now section, which I've literally got on Clinico. So the young ones go, shit, I've just ticked the hypermobility box. What do I do? And you can talk them through it, have an understanding of what they're more likely to be vulnerable to, what they can do at home, what they shouldn't do, what type of exercise is more prescribed for them. Get into the Pilates, the EP side of things to stiffen them up. And they go, stiffen up? What? Are you crazy? But I feel stiff. No, you're not stiff. You're hypermobile. So once you've ticked that box, you've got a whole line of things that you should do, and the ability to then verbalize that to the patient, and then you can either, as I said, refer or rebook. But if you don't have those boxes and don't look for them, and you do what our RTOs are currently doing, a lot of them, unfortunately, is that look for stiff stuff and treat it, and that will, in some type of miracle, change their function and pain, which, as you know, both just doesn't occur. Do you want me to just talk through those things, just each one, for a minute or so?
Yeah, I think that's a really good idea. But I just want to add on to that. I really liked how you sort of, you've mentioned other modalities, and I think the important takeaway from that is that you don't need to be good at everything, especially when you're starting out. You may not be the expert in strength and conditioning. You may not be the expert in delivering nutritional advice or addressing psychosocial contributors. So that's where it is important to use that multimodal team and do things that you can do that you're good at, and then where you see those other potential contributors, refer out. And it's not that you're referring out to get rid of the person. It could be that co-management approach. And I know, Brad, you guys use it so well with your ex-phys there, and that sort of collaboration with the manual therapy and exercise. It really works well. So
You've
that's
got to have
valuable.
the patient in mind. I mean, if you work in some tiny little town, you might have to be jack of all trades, master at none sort of scenario. But if you work in a big city where you've got plenty of people referred to, you've got to refer out. It's what you would want to happen as a patient. If you went to see, say, an osteo, and the osteo said, look, I can do this, this, and this, but you have to see this person down the road because he's so much better at me with exercise rehab or whatever it is. You think, oh, thanks, that's fantastic. You don't lose that patient. You gain their trust. And then you gotta go see this osteo because, wow, they great treatment, but gave me some great advice of who to go see. And that's where I've been huge on that. I'm very fortunate career at the AAS where I saw it work in practice, where you'd have 5 or 6 modalities: biomechanics, exercise, phys, strength and conditioning, all debating one athlete. It was amazing. And then you can see, oh, that's what they can attribute to this and so on. So you try to do that. It's hard because sometimes the business model can be too important to other people. To me, the business model has never been, well, it's important, but I find that the more you give, the more you get back. And so we got a lot of really good referrers now that appreciate what we do with a skill set. We don't pretend to do anything more than that. I know what I'm good at and I know what I'm crap at. So that's why I've got ex-phys and I've got a whole list of referring people that I've got. And we refer backwards and forwards. We call and say, hey, listen, Bo, I'm sending this person to you. This is what I've found. What do you reckon? Really appreciate your input. And then they'll refer them back. So but if you don't have those 10 boxes to tick in the first place, you might not even look for that hypermobility. And if you don't look for it, then you're not going to plan or have a strategy around the hypermobility. Plus, you might not know who to refer to anyway. So just from that one box, you think, wow, I've got a lot to learn here. Because if I do tick that box, what am I going to do? Geez, I need to find some Pilates instructors, some EPs, and people that I can go, hey, Jono, I'm sending another one to you. Extremely hypermobile. Knock yourself out, mate.
Yeah, and it's so important, isn't it? And I guess those clinicians that are fortunate enough to work in larger clinics like yours, the importance of intra clinic referrals, so referring within the clinic to someone who may be a bit more experienced in a certain area. I mean, I sort of tend to get quite a few second opinion referrals, and it's not because I'm going to take over that patient. It's that someone refers to me to get my advice, my opinion, and then I'll send them back for ongoing management there. And that's really valuable. So I think for those new grads, don't be afraid to, or anyone for that matter, don't be afraid to refer out to someone to get their opinion and advice, and don't have that fear of losing that patient, because at the end of the day, you've built that trust and rapport with them. They've got an alliance with you. So yeah, that's
it's a huge mistake in my mind. We refer out a lot of people all the time, and you remember on Thursdays we have our tute every Thursday, main tute, and we get a lot of people come in. So we had a big group of osteos that come in that we refer to quite a bit, and they talked about what they do with certain conditions, refer back and forth. We've got women's health physios that are like hen's teeth 10 years ago, but now they're everywhere and they're fantastic. So I'm like, well, this looks like a potential women's health issue. Refer off, give them a call. Hey, I'm sending another one. You don't lose those people because they'll send them back because they start to appreciate your honesty and your sincerity. And you form this huge team which you become a part of. And I love that concept, to be a part of a team where I think there's something really going on with this patient. You can ring up a sports doc. Hey, Wilson, something crazy going on there. I'm not sure what's going on. We've got A, B, and C. Yeah, send them across. I'll fit them in. And then rings back. Yeah, mate, I'm going to send them off at blah, blah. Could be X, Y, Z. if you don't have that team or you're trying to hold on to them all, you're going to stuff the patient up because you're not going to have the overall skill set to deal with them. They're going to get cranky with you because they'll go see someone else eventually and they'll go, oh, I had a stress fracture. And oops. It can be a very humbling game, this one. So if you don't have the knowledge yourself, surround yourself with people you do. And with a big clinic like ours, where I love it because we've got people who are really good with lymph. I'm hopeless with lymph. I've always been hopeless with it. I've got people that are really good with the upper cervical spine. I'm not good at that. So I think, well, rather than me being good at it, I'm just going to refer to Greg. Greg's great. And people come back saying, man, he's really good with that stuff. So they get the best experience. So that intraclinical referral, really important. Front desk is like your best friend. Front desk, no. Hello, how can I help you? Right, what are you coming in with? An Achilles issue. I'm going to put you in with Jimmy. No, not Brad. He's hopeless with Achilles. We're going to send you to Jimmy. So the front desk will triage to the person that is matching that patient presentation, which means they're going to get the best result because of that person's experience. And within that clinical setting, don't feel awkward. You think, oh, Jimmy's good at Achilles and blah, 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 blah. Where do I fit in? You'll find a spot. You'll definitely find a spot and you'll develop your niche. So you don't need to be jack of all trades in a big clinic or within a big town. You can really start to narrow down. And I always say, make your career fat to begin with. Try everything because you never know what you're going to be good at and what you're going to enjoy. And then you'll start to narrow off. So I'm talking about Jimmy a bit, but Jimmy, he likes treating everything under the knee. And that's it. He can't spell shoulder. No one books any shoulders in. If he does get one, he's like, bloody shoulder. So then you develop a reputation for being quite good at that stuff. That's where you spend all your time researching and remodeling your protocols. Your knowledge base builds and builds and builds. And even in an intraclinical scenario, although I see these guys all the time, sometimes I listen to them talk thinking, wow, that person knows so much about the TMJ now. Like just for that self-massage technique, you got to have your finger that way and not that way when you're wow. So you can start to hey, Wade, what was that about? You're talking about that finger position with self-massage. So their knowledge becomes your knowledge. So I think referring off and having a team around you is just super, super important.
Yeah, 100%. I agree with that. All right, so let's go back to those steps. So where are we at? Step number 2?
All right, so let's go. The concept is have the boxes so you know what to look for and acknowledge each one. And if you tick a box, that means you're going to treat it and you're going to give advice for it and you're going to therefore create a rebooking around that. All right, so you've got a whole strategy there because rebooking, as you know, can be someone's worst nightmare. See how you go. So we've got, is there a swelling component? Yes, no. If it does, have your swelling component protocol ready to go. Is it an inflammatory component? Yes or no. We can't say take some anti-inflammatories, but we can say, look, go down and see a pharmacist. There's only going to be 2 inflammatories anyway. You've got ibuprofen, diclofenac. So one of those 2 is going to be suggested by a pharmacist. You need to get that inflammation under control because the consequence of inflammation are A, B, and C, and I can't get that under control for you. I give some advice to calm things down, decrease loading and so on, but you can also go and see the pharmacist and to hasten that process. All right. Then is there a stiffness component? Yes. That's where we come in. We've got 1,000 things where we can unstiffify people. We can poke and prod and needle and cup and God knows what. So you hope to find a stiffness component. And we're going to treat that, and then we're going to give them some stretching and home-based self-massage around that. And then when we see them again next time, we can assess how their protocol's gone and then either adjust or continue. Then we've got a hypermobility or instability component. That's a bit of both because that's not our forte. So if you recognise they're hypermobile or they're very unstable, you've got to have a team around you, either Pilates or EP or whatever it is. We go, look, I can treat your pain to try and give you symptomatic relief, but in the long term, you really need to stabilise this area and become more stiff, which is always an interesting conversation. More stiff. All right. So the next thing, is there a nerve component? Which is huge for me because I remember when I first learnt nerve stuff and I shook my head in frustration and disbelief that we hadn't been taught it. And then every person that arrived has a nerve component. It might be tiny, but it might be huge. And if you don't know to look for it, if you don't understand how it can completely change your protocol setting, therefore you've got to be able to assess for it. And then you've got to understand how to treat it, how to treat that mechanical interface, and what to give them at home. So you've got a nerve component. It completely changes the way that you assess, treat, and give home-based stuff, especially if it's acute nervy stuff. You ain't going to do anything. You downgrade your assessment, you downgrade your treatment, you downgrade expectations. You basically say, curl up in a ball for a few days. Well, not really. But you have to say, look, we have to calm this thing down, because if you over-treat, it just makes it worse. So is there a nerve component? Is there a postural component? Of course there is. There's always a postural component. Look at your posture. You look like you got a hunchback.
Don't get me started on posture.
So if there's a postural component, is it contributing to that person's presenting symptoms? Yes, no, maybe. So if you tick that box saying, oh God, yes, then you better have your verbal strategy of how you can put that across. You need your options for altering your posture. You might go, you're really stiff within this portion of your posture, so let's mobilize that. This is really weak, let's strengthen that. Don't stay in the same posture all day, because there's no such thing as a perfect posture. You just need postural options. But you need that verb. So if you tick it, you need to go, all right, tick it. This is what we're going to do. Sometimes I go, man, I know you've been told you got thoracic outlet, but your posture, we need to. And sometimes you just get people into a reasonable posture and they'll go, oh, that feels better. So you've got to have that ready to go. And we should be good at that, yeah. So is there a conditioning component? Some people have just been sitting around for years doing nothing. And they're just slowly sinking down. You think, when's the last time you moved? So you think, wow, if this person won't move, I'm just going to be treating symptoms. I don't feel comfortable with that. I need to get them moving. That's a good conversation. But if it is a conditioning component there, you have to let them know, look, if you don't start to move at you're 35 years old, you've hardly got any muscle mass. Your future's vulnerable. And it's a hard one to have. And experienced therapists do it well. Young therapists fumble with it. So but you need to understand that is a component, because it will change your expectations. Is there a degenerative component? Do they have a known chronic degenerative facet joint? And every time they extend, ouch, and then you get muscle spasm and referral, maybe some consequential nerve stuff. So if you know that, you think, all right, I'm not going to fix this thing. I'm just going to get them into an environment where you're going to have the least vulnerability and it'll settle. Once you settle, don't go into a quadrant. Please don't reach up like that anymore, because it's a cranky old degenerative osteoarthritic joint. Every time it gets cranky, it'll tell you. So do they have that component? Do they have an anxiety or that component, which is that biopsychosocial model? They're tough, especially for the young ones. You're a 20, 21-year-old person that's got a 60-year-old coming in, you think they are stressed to the eyeballs. They've got hypersensitivity everywhere. As a 20-year-old telling a 60-year-old, they're stuff, isn't it? So you have to develop that or refer off. Go, listen, I'm going to treat these parts that I can see here, these 3 boxes I've ticked. I'm going to refer you to Wendy, and she's really good with some of these other components, much better than I. And then say, hey, Wendy, this person's so stressed, I don't know what to do. So, but you need to recognize that it's there. And while you're developing your skill set to deal with that, make sure you've got other people around that can help in the meantime. And the last one is, do they present with a known condition? So if someone presents with spina bifida, then you need to know what is spina bifida and what's the prognosis, how does it change with time, what can I achieve? Do they present with cerebral palsy? So have they got diabetes? If they tick that box, just don't go, you got to understand with some diabetes that you'll end up with peripheral neuropathies because of the vascular issues they have. So instead of going, I think this person's got a nerve component, think, well, they've presented with a known condition, and these are the symptoms that come with that known condition. Now that sounds a bit scary because there's a lot of pathologies out there, right? But that's what happens with time. You slowly build your knowledge base. But if you can start off with those 10 little points, then you know where you've got to learn.
Yeah, and it's so valuable when we think about those as contributors. It's not always just one of those things. Sometimes it can be, but obviously, when we think about pain and the multifactorial nature of pain, addressing those contributors, like there might be a bit of a neural component, there might be a little bit of a mood related component to this, there may be a loading or a tissue capacity component here. And so that will then help structure that treatment planning going forward, and it'll as you said, allows you to sort of refer out where needed, understand things that you can manage yourself, but also frame that to the patient so they've got some understanding in going forward.
And that's it. And that's where, again, these 10 points, people end up with pain or dysfunction. And that's just obviously the body going, look, we've put up with this for long enough. We can't put up with it anymore. Can you please deal with that hip? And you go, oh, gee, what's going on with my hip? So they say, take away my pain. But what is the pain coming from? As you said, it can be a combination of 4 or 5 of those things. It could be one main factor and a few others. You get consequential nerve stuff all the time where people don't even know that they've got a lot of deconditioning of a particular area, or they've got a really cranky facet jointed T12L1. They don't even know that because sometimes they're not painful, as we know. But then it sets up a little bit of spasm. The spasm starts to irritate the superior cluneal nerve, and you end up with glute pain. And so people come in with glute pain. But the treatment's going to be well away from that area because you've gone through the boxes and gone, there's a nerve component to this. Which nerve is it? Superior cluneal nerve, which comes from that area of the body. This is mechanically interfaced. Oh, wow, look at the degeneration here, or look at the atrophy here. So again, having all those boxes tick, you think I might have to deal with 5 boxes just to take away their pain, of which 3 of them I can deal with and 2 of them I'm going to have to refer off for. Again, at the end of it, I actually show patients sometimes saying, these are the 5 boxes I've ticked, right? I can deal with these 2. You have to do this one, but I'm going to send you off for these 2 to someone else that's got better skills than me. And they're always happy. I've never had someone go, oh, that's crap, I'm not doing that. And therefore, the 2 boxes that I'm going to deal with, I want to see you in 5 days, 10 days, whatever the case may be. And your homework is this. I want to see if you can complement my treatment. So when they come back in, how have you gone? Wow, that range of motion feels good. Well, actually, this one's not great. We're going to have to change our strategy. Yeah, that portion was easy to do. This one I'm really struggling with. Let's adjust your stretching or your mobility or whatever it is that you're doing. So you've got, again, that structure. So when they come back, you're not guessing. And they're like, a busy week, I've done nothing. All right, let me treat. Let's hasten this process for you. Let's get back on top of it. So you've got that structure.
Yeah, that's so important. And even like, as you mentioned earlier, that whole rebooking process, if you do that well, that's easy because you can then say, well, based on signs and symptoms, your goals and your expectations, we're looking at a minimum 12-week intervention here. And this may look like 1 session a week. It may look like fortnightly after 4 weeks, whatever that may be, but it helps to frame up that overall treatment plan and the prognosis of that condition and the things that will be involved in that, such as strength work, some manual therapy, addressing psychosocial contributors, and that's how it all comes together in a package. So, Brad, I'm conscious of time, so I'm not going to keep you for too much longer, but thank you so much for your knowledge. I'm sure so many people will get a lot of value out of that, and I'm sure we'll do a few more podcasts in the future.
Yeah, if people are interested in any one parts of that sort of stuff, Bo, then extremely happy to pass on as much knowledge as I can. My knowledge is slowly disappearing with that. So, yeah, if people are interested, I love mentoring. I absolutely love it. So anyone that's interested, please let me know.
Perfect. Thanks again, Brad. Really appreciate it.
Good day, guys.
Cheers.